Hi, my name's Lucy. This is my presentation on diabetes insipidus. So, Clark, a 52-year-old male, comes to the ER, reports urine incontinence or loss of bladder control. While in the emergency department for 8 hours, he produces 3 liters of urine. As a result of this excessive urine loss, he is very dehydrated. And because he's dehydrated, the nurses notice that he's excessively drinking water. After they took the labs, they found that his serum osmolality was 310 milliosmoles, and they found that his labs had elevated levels of sodium. And they performed an MRI brain scan showing no major infarctions, bleeding to the brain, or any trauma. So there's two types of diabetes insipidus. So there's nephrogenic, which involves the kidneys, and it involves the tubules of the kidneys to fail to respond to antidiuretic hormone and allowing the kidneys to produce a large volume of diluted urine. And in central diabetes insipidus, you don't get enough ADH released from the hypothalamus of the posterior pituitary. And this leads to polyuria, which is frequent urination, and polydipsia, which is frequent drinking of water. And then there's two types. There's nephrogenic, where I already mentioned that there's two types, but for nephrogenic, I think for both types can be either acquired or genetic. And some common causes of nephrogenic diabetes insipidus can be hereditary nephrogenic diabetes insipidus, kidney disease, lithium toxicity, vasopressin or V2 receptor gene mutations, and aquaportin 2 gene mutation. So for central diabetes insipidus, originates, so like I said, it involves the hypothalamus of the posterior pituitary. So like damage to the hypothalamus, the pituitary stalk, or like I said, the posterior pituitary interfering with production of ADH. And in some cases can be idiopathic, meaning we don't know the cause, could be due to familial and congenital disease. Some of them are Wolfram syndrome, congenital central diabetes insipidus, congenital hypopituitarism, and septo-optic dysplasia. Also, neurosurgery or trauma to either the posterior pituitary, to the posterior pituitary and hypothalamus, specifically. And then infiltrative disorders such as Langerhans cell histocytosis. So when I first heard of like diabetes insipidus, I actually confused it with diabetes mellitus. I thought it was diabetes mellitus, but then I realized that it didn't say diabetes mellitus; it was diabetes insipidus. And those two diseases, this disease is very different from diabetes mellitus. Even though it is like diabetes, it's very different from diabetes mellitus, as we'll see like as we go like more further into the presentation. The disease is very rare, fewer than 20,000 cases in the U.S. every year. It affects one person in every 25,000 people in the general population, and 1 in 4 cases is due to a tumor on the pituitary gland, which can be either malignant, or another word for malignant is cancerous. A related disorder to diabetes insipidus is primary or psychogenic polydipsia, or one excessively drinks water when there is no stimulus for thirst. And then the first person to kind of like come up with a term for diabetes insipidus is I believe, German physician Johann Peter Frank in 1794, when he found that polyuric patients were receiving large amounts of diluted urine and introduced the term diabetes insipidus. So for risks, a lot of the risks correlate with nephrogenic, and a lot of them correlate with, some some of them correlate with nephrogenic, and some of them correlate with central diabetes insipidus. So like Sjögren's syndrome, polycystic kidney disease, aquaporin 2, and vasopressin receptor abnormalities, and then also hypokalemia and hypercalcemia, which decrease the tubule responsiveness to ADH, and then male gender, specifically for nephrogenic diabetes insipidus, but women can still have the ability to pass their gene onto their children, and any drugs that like damage the kidneys, that's specifically for nephrogenic because that involves the kidneys, and then things like septal optic dysplasia, hypothalamic injury, or like surgery to like the hypothalamus, and then pituitary disorders like congenital hypopituitarism that affects like the function of like the pituitary gland. Those are more for like central diabetes insipidus, and then genetics also plays a factor as well. So ADH, antidiuretic hormone, that plays, it's basically the framework, I guess you could say, for like this condition. Like it's very, very important in this condition, as you'll see. So another like name for ADH, antidiuretic hormone, is vasopressin. So it acts to be able to maintain blood pressure, blood volume, and content of water in the kidneys by controlling how much water and the concentration of urine that gets excreted in the kidneys. And then ADH is released from the base of the brain in the area called the hypothalamus from posterior pituitary. And then nerve cells are responsible for transporting the hormone down their axons to the pituitary gland, and is then released into the bloodstream. Its main role is to be able to conserve the volume of fluid in the body through reducing the amount of water that is passed out in the urine, and it can do this by letting the water within the urine to go back into the body in a specific area in the kidney, and that area is the collecting duct, which is very this process is reabsorption, so it's reabsorbing the water, and ADH is able to kind of like regulate the amount of water that is getting like excreted into the urine. And as we can see, as we'll go into like just in a minute on like the actual like pathophysiology of the actual disease, that there's issues with in this disease with like the excretion of water in the urine, and how the ADH function is like failing with that. So I'm separating the pathophysiology for central and nephrogenic. So for central diabetes insipidus, so like I said like earlier, it starts when there is either, it can be a partial or complete not enough secretion of the ADH, antidiuretic hormone, by the hypothalamus within the posterior pituitary. And also, I guess I should have like mentioned this earlier, but when trying to like kind of like remember like the function of ADH, when you hear like diuretic, you can think of like water, so you could kind of like correlate like the function with the name. But yeah, just kind of like a good way to like remember the hormone and like its function. So this partial or complete insufficient secretion causes one to not be able to regulate the balance of water, and this results in free water excretion, just a bunch of water being excreted into the urine, and it makes the urine a lot less concentrated because it's diluted or watered down with lots of water. And this large amount of diluted urine results in an increase in plasma osmolality, and since one is they're constantly urinating this very diluted urine, so they're losing a lot of water. It obviously, when you don't have enough water, you become very dehydrated, and when you're very dehydrated, you become really thirsty, which polydipsia, so you're excessively trying to replenish those fluids, and then also a result from like the dehydration, not enough like water levels, is hypernatremia, and which is the increase in serum sodium in the body. And then, so for nephrogenic diabetes insipidus, what makes this different from central diabetes insipidus is that, unlike central diabetes insipidus, the ADH, it still like functions as normal, but the kidneys, they don't respond to the ADH. So ADH, there's like, it functions like, it's not like there isn't insufficient secretion like there is in central. It's just the kidneys don't respond to that ADH. And there isn't like an exact cause, but it, like I said like earlier, with the different causes for it, but also like it can more specifically be due to aquaporin or vasopressin receptor abnormalities. It's really hard to see this slide. And this leads to the kidneys not being able to properly concentrate like urine, and because of that, once again, the urine becomes very diluted with water, and you're losing a lot of that water. You're becoming very dehydrated. So polyuria, you're frequently urinating, and then polydipsia, you're trying to replenish those fluids, and then hypernatremia, the increased sodium. I also didn't mention in the previous slide, but hypernatremia can also be due to because of the decrease of like water, like not getting enough water. There's an increase in particles or osmoles in the blood.